Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Isabelle Ray-Coquard from the Centre Léon Bérard in Lyon, France, and Dr. Bernard Doger de Spéville from the Start Madrid University Hospital in Madrid, Spain. They will be discussing important new clinical trial data for endometrial and ovarian cancers presented at the virtual 2021 ESMO annual meeting. This episode is part of a larger educational program entitled 2021 Global Conference Coverage, an update on the clinical development across gynecologic malignancies. For more information on Dr. Ray-Coquard and Dr. Doger de Spéville, along with a link to the complete program, including a downloadable slide set and clinical commentaries, please visit the show notes for this episode. Now let's get started and hear what the experts' thoughts on some new results presented at the 2021 ESMO annual meeting.
My name is Isabelle Ray-Coquard, medical oncologist in the Centre Léon Bérard, Lyon, France. I'm also the president of the GYNECO group, the cooperative national group dedicated to gynae cancer. And I'm very pleased today to be with Dr. Bernard Doger from Madrid. He's a medical oncologist 2, team member in the early phase clinical trial unit of the Start University Hospital in Madrid. And both together, we will work on what's happened in ESMO. We have selected some key trial dedicated to gynae cancer to discuss with you and to report the key message for this trial. Dr. Doger, a word from Madrid.
Thank you very much, Professor Ray-Coquard. It's really a pleasure being with you today.
So we will immediately move in the science. It is so important for us. I will speak about 3 referent papers. One is a phase 3 trial, OReO, led by my group, and I'm very proud to be part. This trial asked the question of PARP after PARP, and specifically to rechallenge a patient who already received PARP before and who respond again to platinum-based chemotherapy if there is some interest to reintroduce olaparib versus placebo. It is a trial including 2 cohorts of patients, BRCA mutated or non-BRCA mutated. The patient have to receive between 12 to 18 months of PARP inhibitor before for the BRCA mutated population, less for the non-BRCA mutated population. And after a partial or complete response, they could receive olaparib or placebo. The trial include a majority of patients who received several lines of treatment before, more than 2 in general, and we observe a positive effect in the BRCA mutated cohort of patients with an hazard ratio close to 0.5 and a median benefit of close to 2 months in this population. Interestingly, close to 20% of the patients were progression-free in the olaparib arm versus the placebo arm before 1 year. In the non-BRCA mutated population, again, we observe a statistically significant effect with an hazard ratio close to 0.5. And in this cohort of patients, we see that close to 15% of the patients receiving olaparib were progression-free at 1 year. There is no patient free of relapse at 1 year in the placebo arm. In terms of safety, we did not observe new safety issue for olaparib than before. The second randomized trial presented at ESMO for the oral session is the NRG-GY005 trial exploring the combination of cediranib plus olaparib versus chemotherapy in platinum-sensitive relapse. This presentation is dedicated on the HRR mutation subgroup and exploring the impact of the LOH test in this clinical trial, who I remember you finally did not report a significant improvement using the combination of olaparib in monotherapy in this trial. The presentation reports a prognostic impact on the HRR score on the progression-free survival in this trial. Unfortunately, we don't see a benefit in terms of prognostic to be LOH positive compared to LOH negative test. And in terms of prediction of efficacy of PARP inhibitor alone or in combination, we see an advantage in the HRR mutated group and no benefit were reported in the LOH positive group compared to the LOH low group. The last one, we would like to speak about, again, PARP inhibitor in first line with the PRIMA phase 3 trial, but we would like also to explore the impact, not looking only to efficacy, but also on quality of life. And what's happened in this poster presented at ESMO is that in the PRIMA trial, we see a positive and statistically improvement in terms of quality adjusted progression-free survival, but also quality adjusted time without toxicity using maintenance with niraparib versus placebo in the all-comers population, but much more importantly, also in the HRD positive group, where we see the maximum of efficacy in terms of progression-free survival.
So thank you very much for your summary. I would like to ask you regarding the OReO trial about the safety and, one of the toxicities that it's hopefully is not very common, but it's true that it's very challenging, which is the myelodysplasia for these patients treated in these trials.
Thank you very much. I agree with you. It's an important topic. Specifically, we are in relapse, so we have to consider to rechallenge until progression. It's not for a fixed time. And so we have to be very careful in terms of myelodysplasia, leukemia, and secondary malignancy. What we have seen with OReO until now, there is no major toxicity compared to placebo. So it is a good point for us. Now, I have to say that we have to wait also for the overall survival data and long-term follow-up to be sure that what we observe today is the reality, because it could be an issue for the patient.
Yes, and also may have an impact in further treatments. Yes, also, I would like to ask your opinion about the reproducibility of the test of the HRR, because not in all centers these tests are available, and I don't know if in the regular practice and not within a clinical trial, and we will not see the same results as we have seen on the trials.
I agree with you, Bernard. For the NRG-GY004 trial, it is a little bit complex for me because they report the HRR test, but 90% of the patients were finally BRCA mutated. And so we know, and we have definitively the information that a BRCA mutated patient were really sensitive to olaparib or to the combination of olaparib plus cediranib. So what it is important to remember is that finally in this HRR test, there are very few patients beyond BRCA. And it is completely different that we have published with other tests. Now moving to HRD, what we observe in this trial is that the LOH test did not predict more efficacy of olaparib plus cediranib or olaparib alone compared to LOH low. That means that in relapse, this test is not sufficient to select the candidate, and probably, as we have seen in REL3, for example, platinum sensibility is the best test to identify the best candidate for PARP inhibitor in relapse. But we are speaking about patients in relapse. In first line, we know with Myriad that it is completely different.
And should we retest these patients after progression? I mean, should we test this patient after diagnosis and then after the first progression, or should we rely on the first results?
What we have understand right now is that we have a complete reproducibility in the REL2 trial where we have per biopsy between the results of the test in archival tissue versus in relapse. But what we know also is that HRD tests, LOH or Myriad, are finally scarce and did not reveal the ongoing sensitivity to PARP. And we can have a positive test in relapse. However, the patient is already resistant to PARP. So it's quite complex, probably because of the test, and it is a consequence of the gene mutation. And in this case, in particular in relapse, we are not sure that HRD test, whatever, will be of interest to identify the candidate for PARP.
Oh, thank you very much. And my last question about quality of life regarding the HRP population.
As we have seen that in the HRP population, the median PFS adding PARP inhibitor to first-line chemotherapy is not so high. It will be important to see what's happened in terms of quality of life. I fully agree with you.
Yes, thank you very much. I'm highly delighted to review and discuss with you the expected data of these two trials presented in this ESMO 2021 meeting. The first trial I would like to highlight is the EOR-TC1508 study presented by Dr. Bernard. This is a phase 2 multicenter study of bevacizumab as single agent and atezolizumab and bevacizumab in combination with acetyl salicylic acid, ASA, or placebo in a very challenging population, which are recurrent platinum-resistant ovarian cancer. This trial has a very interesting but not very well explained rationale of how to improve response to immune checkpoint inhibition and avoid immunosuppression in the tumor microenvironment. The hypothesis is that the blockade of PGF with bevacizumab and prostaglandin E2 with ASA can reverse the endothelial barrier, allowing the T-cell infiltration and subsequent T-cell activation by PGL1 blockade in the tumor. This rationale led to the design of this 5-arm clinical trial where refractory patients were excluded. These patients were allowed to receive previous treatment with bevacizumab or other VEGFR inhibitors and were randomized to one of the 5 arms, bevacizumab as single therapy, 2 arms with atezo, with placebo or with ASA, and also 2 triplet arms with bevacizumab plus atezo plus placebo or ASA. Arms 2 and 3, the ones with atezo alone and atezo plus ASA, were prematurely closed due to the results of the phase 3 trials with avelumab that were published in November 2018. So the data presented in this ESMO meeting are mainly regarding the 132 patients enrolled in arms 1, 4, and 5. The primary endpoint of this trial is progression-free survival at 6 months, and secondary objectives, other endpoints of efficacy such as PFS, overall survival, tumor response at time to first subsequent therapy. And I just want to do a brief summary of the patient characteristics. The median age was 62.5 years. The majority patients have a serous carcinoma histology. 84% received 3 or more lines previous to be enrolled in the trial, and almost 70% have a previous bevacizumab or VEGFR inhibitor as part of this prior treatments. In terms of efficacy, the primary endpoint was not met as the activity threshold established by a protocol of at least 12 after 29 patients need to be alive and progression-free at 6 months. This endpoint was not reached. And the percentage alive and PFS at 6 months ranged from 20 to 27 6 months if we compare the triplet with placebo and the triplet with ASE. The response rate was the 9.7 in the bevacizumab alone arm and increased to 19.4 and 50% in the triplet arms. Also, the disease control rate was 58, 77, and 76 respectively. PFS was also numerically improved, but with non-statistically significant results from 2.3 months to 4 months. The time to the first subsequent therapy the median time was 3.2 months in the bevacizumab arm, with a significant improvement to 5.3 and 5.8 months for the bevatizo and the placebo and the bevatizo and ASA. But it's true that no differences were observed in terms of overall survival. It's important to remind that the monotherapy arm had the permission to cross over to the atezo plus bevacizumab arm once progressive disease were documented. The main common reason for treatment discontinuation was the radiological progressive disease, but we'll focus on the toxicity, as 3% in the bevacizumab single arm were documented, and 70% on the of adverse events were reported in atezolizumab and placebo. About grade 3 or more toxicity, 48% were seen in the bevacizumab arm alone, and around 30% in the triplets with ASA or placebo. So we may conclude that the addition of ASA does not increase the number of grade 3 or more adverse events. I have not mentioned before, but serum, PBMCs, and biopsy samples were taken at baseline and pre-cycle 3 of 87 patients of all arms, and 72 in arms 1, 4, and 5. So this analysis that includes PD-L1 expression, immune tumor microenvironment, and tumor endothelium analysis, TILs and TCR sequencing, and transcriptomics are expected and to identify new biomarkers of clinical benefit. So in conclusion, Israel didn't meet the primary endpoint of efficacy, but it may open further exploration of combination of atezo and bevacizumab in this challenging population, and it has been shown without increasing toxicity. The second trial I would like to highlight is the update of the Keynote 775 that was previously presented at the SGO 2021 meeting. And this update that was presented by Dr. Colombo focused mainly on the outcomes of patients treated with lenvatinib plus pembrolizumab versus treatment of physician's choice, such as paclitaxel or doxorubicin in advanced endometrial cancer. The combination of pembrolizumab and lenvatinib improved in the intention to treat population, the PFS and the overall survival in all comers, with a hazard ratio of 0.56 and 0.62, respectively. And this benefit was also observed in the proficient mismatch repair patients. The data presented of the post-hoc analysis provided also efficacy outcomes in PFS for different histologies, such as endometrial serous and clear cell endometrial carcinomas. And we may also say that this benefit is observed regardless the number of prior platinum-based lines, and if progressive disease was documented within or after 6 months of the end of treatment. In terms of overall survival, this benefit is confirmed in all histologies, and this effect is observed in patients with 1 prior line of platinum, but not if they have received more than 1 line. No new toxicity data were reported during this meeting, and it's true that the design of this trial did not have the power for this post-hoc analysis, but these results may offer new treatment options for these patients.
Thank you very much, Bernard, for this nice presentation. I have 2 questions for you. For the first trial, what is your feeling? You are very familiar with early phase trial. What is your feeling about the role of ASA, and for the future, do you consider to continue to explore the combination of atezo plus bev plus ASA, or do you leave the ASA considering the results report today?
Well, it's true that during this meeting, the rationale of adding ASA to this combination of atezo plus bevacizumab was not completely explained. I don't think adding ASA has not improved the efficacy data. So I don't think that ASA needs to be included in further investigation. The main exploration should be regarding the combination of atezolizumab and bevacizumab.
And thank you. And about the Keynote trial, very interesting results by histological subgroup. I'm a little bit surprised for the clear cell carcinoma. We see not so much results in terms of PFS compared to endometrioid, for example. However, the overall survival results data is very good. Do you think that it is because there is a lot of MSI in the clear cell subgroup, or what could be the explanation?
Yes, I think so, because it has been documented previously that clear cells have shown an increase of mismatched repair deficiency and poly alterations if we compare it with other histologies. So maybe this may something to do with these differences between PFS and between overall survival. And so that these tumors have an increased CD3 and CD8 positive T cell population infiltrating the tumor microenvironment, and also they usually have an increased PD-1 and PD-L1 expression. So I think that maybe is something that we need to explore, and we need to have more data about these biomarkers in the future.
I agree. We need to develop more translational research in endometrial carcinoma, as currently we don't have so much information. A last point about toxicity. You did not mention anything by histological subgroup. Have you seen something on that?
No, well, it's true that during this meeting, this data were not presented. It's true that in this trial, the lenvatinib dose is 20 milligrams. That may be a high dose for the regular practice, and I think that will be a challenge to keep this dose in all patients that are not treated within a clinical trial because of comorbidities and previous medical history. But it's true there has been previous data of treatment emergent adverse events leading to treatment interruption, and lenvatinib treatment with a high incidence of grade 3 and more, of about 95%. So, well, it would be a challenge, and we'll need to explore also the tolerability, if this may have an impact also in the treatment and also efficacy.
Thank you so much, Bernard. I agree with you. There is more a question than answer, and it's good for the future. This will conclude for this podcast dedicated to ovarian and endometrial carcinoma, virtual ESMO 2021. I hope that we will help you to understand, manage your patient in routine practice. Thank you so much, and see you soon.
Thank you very much, Dr. Ray-Coquard and Dr. Doger de Spéville, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, 2021 global conference coverage, and update on the clinical development across gynecologic malignancies, and to download a highlight slide set including the various studies associated with this discussion, please click on the link in the show notes. As always, thanks for listening.